So good evening, everyone. For those of you who are new to my webinars, my name is Cameron Collins, lead podiatrist and co-director at Fungal Nail Solutions in New Zealand, as I've already been introduced. For those of you who have listened to one of my previous webinars, welcome back. Must be saying something right if you've managed to come and listen to me for a second time. Now, tonight I'm going to present to you all webinar 2 of our 3-part webinar series. And tonight's webinar is going to look at managing patients with onychomycosis. We're going to discuss the key factors in patient management, including identifying challenges and determining appropriate treatments for these challenges. We're also going to learn how to educate patients, set realistic treatment outcomes, and provide ongoing support to achieve successful treatment outcomes, which as clinicians, I think we all strive to achieve. So before we begin, a little bit about tonight's agenda. So firstly, we're going to kind of briefly understand the elements of managing patient expectations, or the elements that I think are important when managing patient expectations. Then what we're going to do is we're going to spend a lot of time looking at the factors that help us identify patient challenges, which I think are incredibly important. And in turn, this will help us determine appropriate treatments and manage realistic patient expectations. The factors that we're going to touch on a lot tonight are both patient factors and local factors. And then briefly, we're going to talk about mycological factors. And finally, we're going to start to put all of this information together in a short case study series, which will then lead in quite nicely to webinar 3. So we've all had the patient in our clinic, and I can hand on heart say I've had plenty of them, who've spent an absolute fortune on various treatments, have adhered to everything that we've asked of them, and they present back into our clinic 6 months, 8 months, 12 months later with little to no improvement. Now, as clinicians, and speaking for myself only, I certainly dread these sorts of conversations and sometimes struggle to understand or know what to say to give the patient hope or reassurance that we have the answers for them. Now, managing patient expectations is an important aspect of treating fungal nail infections, as I think it really helps us set realistic goals and ensures that patients understand the limitations and challenges associated with treatment. So first and foremost, what I've done is I've broken down the key areas that I think are really critical in managing patient expectations and treating fungal nail infections, which I look at addressing all of these elements with all of my patients that walk through my clinic on day 1. So the first one is all about educating patients about the nature of fungal nail infections, which we talked a lot about in the last webinar. We discuss all treatment options with patients, and I think it's really important that we put all our cards on the table and the patient makes a decision as to which pathway they wish to choose. We set realistic treatment outcomes for patients. If a patient commits to the treatment, let them know what kind of realistic outcomes you expect from the treatment. We want to emphasize the importance of adherence to a treatment plan, and I think that's a really, really important one. Provide realistic timeframes for results. Make sure patients know how long that treatment journey is going to be. We're going to discuss potential challenges and setbacks relating to the patient that's sitting in front of you. And of course, we're going to provide ongoing support and communication throughout that full treatment journey. And that's what I think, in my opinion, helps us really get our buy-in from our patients when they have the opportunity to communicate and understand what we're thinking as clinicians. However, as time is of the essence, I thought we'd spend tonight's webinar kind of looking at the following aspects on screen. So we're going to really hone into discussing potential challenges and setbacks with patients relating to their fungal infection. And in turn, I think this works in quite nicely with how we better discuss treatment options with patients and helps us set realistic treatment outcomes for patients as well. So, discussing potential challenges and setbacks. So this is, as I said, probably the most important aspect for me when managing patients. So every patient that attends my clinic has a set of negative and positive prognostic elements relating to their treatment journey, whether that be mycological elements, patient elements, or local elements. All of these elements, or what I like to deem them as factors, which we'll talk to very soon, must firstly be identified through that thorough subjective and objective examination and subsequently discussed with the patient. Allowing a patient to understand what aspects of their infection might make their infection more stubborn can help a patient understand that setbacks may occur. We want them to understand what elements of their infection might be stubborn to respond to treatment. We want patients to understand that these factors may require further intervention or combination therapy, or a patient needs to understand that these factors might mean that a plan B, C, or D is required a little bit later down the track. But also being able to identify factors, we're able to better understand what treatment options are available and suitable to the presenting patient, creating more of an individualized treatment plan. So with all of that in mind, how do we tailor a treatment plan to an individual that takes into account challenges or factors associated with the presenting patient? So in order for us to be able to identify patient challenges and therefore be able to select the most appropriate and successful treatments for our patients, we must be able to first identify the factors that are likely to influence our clinical decision-making. So in our clinics, we tend to collect and identify all of this information that I'm about to present to you, either through a subjective or objective examination, which in turn helps us create really useful conversations with patients about patient expectations, about treatment that they're about to purchase and embark upon. Okay, so these are the factors that really we start to look at. So the first factors that we look at are patient factors. So these are things like our circulation, peripheral vascular disease, diabetes, whether there's some sort of history of a previous episode of onychomycosis, immunosuppression, and other health-related factors, their sex, their age, compliance to treatment, family history, occupation, lifestyle, behavioral factors. Then we start getting into the local factors. So does the infection presenting to us have a lateral edge disease? Is there extensive onycholysis? Do we have dermaphytomas or spikes present? Do we have matrix involvement, slow nail growth? Are there other nail diseases like psoriasis presenting on the nails? Do we have traumatically damaged nails? And do we have sort of thick hyperkeratotic nails as well? And then we start to dive into the mycological factors. So do we have a mixed infection present? Do we have a fungal, bacterial, or viral infection? Do we have difficult to treat organisms presenting on this nail, such as our candidas and some molds or some non-dermatophytes? And the last thing is some of these presentations of mycological factors are very resistant to antifungal drugs, something that we have to consider. And finally, although I'm not going to touch on it tonight, I thought it was a really nice interlude. The severity index is a onychomycosis objective measurement tool, which takes into account a lot of these factors. And generally speaking, the higher the score, the poorer the prognosis. So all of these factors I talk about tonight, and if we think back to our own case studies that we have in clinic at the moment, if you're kind of in your head going, yep, got that, yep, got that, yep, got that, all that's doing is increasing their severity index score. And so generally speaking, prognosis long-term to treatment is going to be poorer. So please note, before we start to dive into the local factors, I will be discussing these elements as individual prognostic factors. However, it is likely to change if we are considering multiple prognostic factors in one case. However, this discussion is more so designed to try and increase awareness of the types of things that are influencing our decision-making and aspects of our assessment that are worth spending time talking to patients about. I'm here tonight to present to you with all the current research or research that I've looked into to help us with our clinical reasoning and decisions in clinic. And as everyone is aware, there is limited research specifically on the cold laser treatment, particularly when looking at these various factors. However, this webinar is designed to more or less help you have a deeper conversation with patients about their presenting fungal nail infection and help create better patient expectations about treatment. Not really here to share my opinion as such, but I will throw in a few bits of my clinical experience along the way. And then obviously we've got a bit of Q&A at the end. So without further ado, massive introduction, but let's kind of get into it. So local factors are where we're going to start. So the first aspect that I want to just talk to is fingernails versus toenails. Now, in general, fingernails are more easily able to be treated and usually require shorter treatment periods. The higher success rate of therapy in onychomycosis of fingers compared to toes may partially be explained by the fact that they are thinner and grow faster compared to the toenail, but also things like better circulation may apply and explain this. Therefore, as a general statement, I tend to suggest to patients better long-term prognostic success if a patient presents with fingernails over toenail fungal nail infections. However, what I will say in the same breath on this segment is that fingernails are far more prone to our mimickers, which we talked about last time. So please watch out for these. And also fingernails are more commonly, in my clinic anyway, presenting with yeast infections, which I do not believe respond as well to some treatments, which we'll talk to a little bit later once we dive into the mycological factors. The amount of nail involvement. So the percentage of onychomycosis involvement is often considered to be an important prognostic factor and used to select the type of treatment used, and as part of an inclusion criteria in a lot of clinical studies involving onychomycosis. So normally I'll classify patients' infections into kind of less than 25%, sort of a moderate infection being sort of 25 to 75%, and a severe infection being sort of greater than sort of 75, 80% of the nail. Now, the reason I do this is because I think there's a general perception that the less the nail involvement is, the better response to treatment. However, this has kind of been really difficult to prove in clinical studies. So in a study on 496 patients treated with either oral terbinafine or intermittent itraconazole, cure rates did not correlate with nail involvement. Contrary to that, in a study on topical terbinafine, the cure rates were higher in patients with less than 40% involvement. So what this is kind of telling us is that this factor may be a greater importance when we're using topical drugs. So in essence, if a patient has an infection of less than sort of 30 to 40% nail involvement, they're far more likely to respond to some forms of monotherapy, such as topical solutions. However, the coverage of nail plate is less likely to suggest, doesn't mean it's not going to work, but less likely to suggest whether oral medication is going to actually be successful or not. Lateral edge involvement, and obviously all the pictures involved with these factors kind of explain what I'm talking about. So patients with lateral edge involvement are quite difficult to treat, even though the coverage of nail isn't significant. This can be explained by the formation of onychomycosis or hyperkeratotic pockets or canals that form at the lateral edges, and that it's difficult for drugs to penetrate into this space. As we can imagine, and I'm sure we can all visualize, we get our Black's file down that lateral edge, there tends to be a lot of thickened tissue, the nail plate tends to be more elevated. Now, if there is lateral onychomycosis, the concentration of orally administered antifungal agents may be lower compared to the central third of the nail plate, where adhesion between the nail plate and the underlying nail bed is better. In essence, the use of topical solutions and oral medication is less likely to work in these presentations, and this is where we start having discussions about our other modalities, such as cold laser, may be better options in these sorts of cases. Onycholysis, extensive onycholysis in particular. So extensive onycholysis may prevent a topical drug to reach the nail bed. This may also result in reduced delivery of an oral antifungal agent from the nail bed to the adjacent ventral nail plate, as there is kind of like an insulation layer of air that exists between the nail bed and the nail plate. Now, possible management strategies in these sort of cases include extensive trimming back of the diseased nail plate or sort of supplemental therapy. So just like the lateral disease involvement, as we talked to in the previous slide, the use of topical solutions and oral medication is less likely to work in these sorts of presentations. However, patients appear to respond better to oral antifungal therapy when there is minimal onycholysis and absence of lateral onychomycosis. So one barrier, and talking a little bit about extensive cutting back, one barrier that I have with patients around that conversation is they're a little bit reluctant to allow any extensive trimming of the nail plate due to cosmetic reasons. And this tends to happen far more during that summer period, and a lot of people over the ditch probably have that all year round. Thankfully, we're quite lucky not to have that over here from an onychomycosis treatment perspective. But explaining to patients that treatment is likely to be less successful if onycholysis remains gives the patient effectively two options. They keep their nail plate but reduce their chances of success, Or number two, they deal with a less than desirable nail in the short term, but gain in the long term, knowing that if we can reduce extensive onycholysis, treatment is likely to be more successful. Another conversation that needs to be had in this space is that a nail that's been onycholytic for a long period of time can be more difficult to reattach later down the track. So again, looking at managing patient expectations, we may be able to eliminate the infection. However, getting a nail plate to reattach can be a completely another treatment protocol altogether. So again, managing expectations, what you're expecting from treatment. Nail thickness. So it's logical that it can be difficult to treat patients with thick nail plates or subungual hyperkeratosis, as it is likely that it is more difficult for drugs to reach sufficient concentration in the sort of thick hyperkeratotic nails. Now, this has often been suggested in the literature, but statistical support is missing in this space. Now, in a recent study, patients with thick toenails were less likely to reach cure, but the results did not reach statistical significance. Interesting, very similar to the research I presented on the nail involvement. However, the general consensus here is that nail plates thicken beyond 2 mil are far more stubborn to treat, which would align with my clinical experience and also align with the objective measurement that we talked about previously, is that nails that greater than 2 mil are tough. In these cases, I'll always attempt to remove as much of the thickened nail plate as possible prior to beginning any treatment, explaining to the patient that this is imperative and necessary prior to any formal active in treatment, and returning throughout treatment for regular debridement is essential. And this is why I think a lot of people fail over the counter and oral medication and laser and everything else, is that we don't have that regular debridement, keeping that nail plate reduced in thickness. Matrix involvement. So extension of the infection into the matrix is generally accepted as a really negative prognostic factor. And I'm sure a lot of us are thinking, yeah, totally agree. So it is possible that involvement of the nail matrix affects nail growth or other physical characteristics of the nail. Now, there's a study on 199 patients with onychomycosis. 134 of them had matrix involvement. And when factors predictive of cure were examined, the odds ratio for patients with a matrix involvement not reaching cure was 2.591, which is quite high. These presentations are tough, real tough. And once we have matrix involvement, I usually explain to patients that these infections become incredibly hard, well-established, severe, and stubborn to treat. Now, in these cases, I'll always go for a combination therapy type approach. Now, I'm not going to go into too much of this as a little bit of a plug for me in this next little bit, because I don't want to give too much away. I'm actually presenting at the Australian Podiatry Conference next month, specifically discussing treatment of infections that progress down into the matrix, based upon some really cool in-house research that I've been doing and devising a treatment protocol within our clinic that we've been using, and we're getting incredibly awesome results. But I'd suggest coming along next month if you're heading to the conference, if you are interested. And it's always nice for me to have a few more bums on seats as well. So if you're interested in that matrix involvement, how we go about treating it in clinic, I suggest come and listen to the chat next month. Dermatophytomas or spikes. So we did briefly talk about these in the last webinar. So it's consistent of sort of a hyperkeratotic mass with a really densely packed clump of dermatophytes, which are thick-walled. Now, clinically, as we can see in the picture here, these are a really dense yellow area, which are sort of clearly demarcated from the surrounding infection. Now, in this enclosed space, we have a really tightly packed clump of fungal elements. Now, the concentration of the antifungal agent will be lower administered to the dermatophytic area here. So Robertson Evans did a study and suggested that removal of the dermatophytoma or spike was completely necessary. In a study of 199 patients treated with oral terbinafine, dermatophytomas clearly had a negative effect on cure. The negative impact of dermatophytomas on cure is now generally accepted. So the general recommendation here is to remove a dermatophytoma before treatment is initiated. So in essence, the conversation with patients in this space needs to be, patients need to remove the dermatophytoma at all costs, regardless of cosmetic reasons, if we want to try and clear these sorts of presentations. Nail growth rate. So the general perception is that nails that have a faster rate of growth are likely to respond better compared to slow growing nails. And it's simply asking them a subjective interview. Do you feel like your infected nails grow as fast as your non-infected nails? This is supported from the clinical observation that patients exhibiting faster outgrowth are likely to show a better response to treatment. And I would totally agree with this statement. It's really logical, as the infected part is likely to be shed earlier in patients with fast-growing nails. Zeng and colleagues showed that cure rates are much higher in patients with fast-growing nails. It is important that if people suggest they have slow-growing nails, we do explain that this might reduce their chances of success. However, at the same time, I think it's a really great opportunity and an easy factor for us to influence. Obviously, cold laser can help improve nail growth rate, which is fantastic, but couple this with nail growth products such as biotin and other sort of supplemental products, you can reduce this challenge quite easily. Other nail diseases, so if there is coexisting nail disease, such as psoriasis, the response to treatment may be poorer, although this has not been thoroughly studied, unfortunately. Even though the eradication of the fungus is successful, the nail may never become normal because of residual changes caused by other disease. Now, this may be other disease or trauma. The other thing for us to bear in mind here is things like psoriatic nails, ingrown toenails, etc., may also actually increase the likelihood of infection or reinfection. I think there's two kind of key components to this discussion. Correct diagnosis. Although mimickers can exist in conjunction with onychomycosis, it is important to ensure we establish the presence of onychomycosis, which comes back again to my first webinar. Failing to do this may result in an incorrect treatment protocol and a disappointed patient at the end of 9 to 12 months. Additionally, when conditions exist simultaneously with onychomycosis, it is important to manage patient expectations. I quite regularly treat patients with psoriasis and onychomycosis. I have managed to successfully treat onychomycosis, improving the coloration of the nail plate. However, ultimately, they are still going to have a deformed nail as a result of the other disease. Managing expectations. Right, so that's all kind of the local factors. So what we're visually looking at, we obviously get a lot of that from our objective examination. Now we're going to start diving into patient factors, which are information that comes a lot out of our subjective information. First one being age. So several factors related to age can alter the appearance and physical characteristics of the nails. And nail changes are quite common amongst older individuals, which is a pretty common statement, and I'm probably not saying anything groundbreaking here, but both nail changes in general and onychomycosis are more common in the elderly. Younger patients respond better to therapy. So in a study where 24 patients between the ages of 18 and 64 years of age were treated with, in this case, intermittent itraconazole therapy, age was the only parameter that was correlated with the cure rate in the study. In another study, patients over 65 years of age were far less likely to be cured compared to patients between 18 and 40 years. So it is logical that patients with slower nail growth, poorer circulation, taking other drugs, and possible immunosuppression require longer treatment and possibly more combined therapy, something for us to certainly consider with treatment planning and discussion with patients. 6. So male patients seem to be more difficult to treat, go figure. The reason for this, however, is not clear. It is known that in most countries, the prevalence of onychomycosis is higher in male populations, but few studies have sort of compared cure rates between genders. It is possible that men more frequently suffer nail trauma, and men may seek for more advanced disease compared to females. And it's also been suggested that compliance of males may also be an issue. Now, I think this is a really broad statement and probably not something that we really want to base our clinical decision-making on, but a few key points out of this once again: consider lifestyle, footwear choices, activities performed, compliance to other forms of treatment, etc., etc. History of more than one episode of onychomycosis. So patients with a history of a prior infection may be less likely to be cured. This may be explained by a subgroup of patients who could not be cured by the previous standard treatment course and are hence unlikely to be cured with another standard treatment course. This may also be a marker for a patient group with a strong onychomycosis tendency. So in these cases, I'll always tell patients that this is going to be a challenge to treat. In these cases whereby we have had multiple episodes, I'd really start to hone in on lifestyle hygiene protocols to better understand why patients are getting recurrent episodes of infections. Now, for that subgroup of patients who have not really been fully cured and go through this kind of vicious cycle, I definitely consider a sort of throw the bus at it type approach. Now, throwing as much combination therapy as impossible. Now, obviously, whilst taking into consideration the patient and the circumstances. Finally, I think it's really important in this space to get a full subjective history of previously failed treatment protocols to ensure that we do not give them yet another standard treatment course of the same treatment, because I can guarantee they will not be walking back into your door in a couple of weeks' time. Positive culture 24 weeks after starting. Now, this is a really interesting one, not something that I'm not going to preach too much because it's not something we do in clinic, but I think it's important to bring up. So a positive culture at 24 weeks after the start of therapy, so not 24 weeks after they've had the infection, but 24 weeks after the start of therapy, is associated with treatment failure. Now, this may help to identify difficult to treat patients for whom a more tailored treatment approach would be indicated, or a more aggressive treatment approach would be indicated. So culture at 24 weeks can therefore be used as a tool to identify patients that are likely to fail a standard course of treatment. If culture is positive at 24 weeks, a booster treatment or further combination therapy should be considered. Family history. Now, I think this is a really, really interesting one, and it's quite different to household contacts. I want to make that really clear. Family history is your bloodline. Household contacts is who's in your house, obviously. So family history. So there is really a strong genetic disposition to fungal infections, which has been established. The evidence that onychomycosis has a genetic component originates from the observation that among individuals exposed to identical environmental conditions and fungal pathogens, some did not develop onychomycosis, whereas others go on to develop chronic infections. And I think this is really common when you ask a patient whether they have anyone else in their household that's infected, and they say no. So you read on Google, says it's incredibly infectious. Then you've got a husband, a male that comes in, he's got a wife, he's had his infection for 10 years, they sleep in the same bed, use the same shower, use the same floors, and she's never picked up his infection. So for what is incredibly infectious, I think it more has something to do with your family, your history, your genetic ability to pick up an infection rather than your household context. So the genetic component that contributes to this susceptibility to chronic disease is thought to be located in the innate or adaptive immune system. So defects in the adaptive immune system response to dermatophytes prevent the subsequent development of the full immune response, thereby rendering the individual vulnerable to this type of infection. Now, this isn't something that we can do an awful lot about, and nor something as we want to test. We do want to find out if their mums, dads, grandparents, siblings, etc. do have a history, all right? Because I think this allows us to place a greater level of importance on setting realistic patient expectations. If someone has a large family history of infections, as well as spending a lot of time on re-infection education, as this group of individuals are far more prone to catching infections and catching infections over and over and over again. So education in this space is really quite king. Lifestyle, and this is one that no doubt everyone already talks quite a bit about in clinic. I'm going to focus particularly on nail trauma in this space. So there are obviously a number of factors that contribute to a patient's onychomycosis prognosis that are quite independent of the severity of their nail disease. Now, this includes patient behaviors such as risk of nail trauma from shoe selection, participation in sports, notably stop-start sports, running, trail running, stairs, hills, things like that, and obviously our hygiene behaviors as well. Now, nail trauma as a standalone facilitates the invasion of the dermatophyte by providing an uninhibited pathway of infection. Chronic nail trauma, or a chronically malformed nail, potentially is forever vulnerable to infection, making sustained clearance incredibly difficult. Now, this can explain why fifth toenails in particular are bloody hard to clear or treat, and retracted digits, clawed digits, etc., etc. So if you have chronic nail trauma, clearance is incredibly difficult to treat. You couple that with someone that runs, wears tight shoes, wears high heels, etc., etc. Life can be really challenging in this space where chronic nail trauma occurs. And of course, let's not forget the use of communal facilities such as swimming pools, gyms, etc., etc. I'm not going to dive in too much tonight. Perfect breeding ground for fungal spores. Health status. So obviously factors related to the patient's health status are critical to prognostic evaluation. So comorbid conditions such as old age, which we've talked about, diabetes, peripheral vascular disease, psoriasis, which we've already talked about, all portend to a poor response to treatment. These conditions often lead to slow or poor nail growth, which again we've talked about. So everything's starting to tie in quite nicely with each other due to poor circulation and or chronic nail trauma, which again we've talked about quite a lot already, which can have something to do with activity or lifestyle, but also diabetic neuropathy, arthritic abnormalities, etc. Obviously immunosuppression, whether due to complications from diabetes, autoimmune diseases, HIV, etc., have a poor response to treatment for onychomycosis, and patients that are immunosuppressed due to one or more of these factors need to be prepared for the possibility of treatment failure. Not saying we can't get successful outcomes with these people, but we do need to understand that we are really fighting a heavy battle in these cases. And the last thing I wanted to just briefly touch on with health status is hyperhidrosis, which obviously creates a really undesirable environment in our shoes and socks. That wet, damp, dark environment creates that real perfect breeding ground for our infections in our toes. Mycological factors. So the last aspect we're going to look at tonight, and there's just a couple of key points that we're going to really touch upon. Obviously, there's a whole lot of other aspects that we can talk to, but I thought I'd just bring up a couple of key points, bearing in mind the time. So as discussed in my previous webinar, the identification of the organism at play is important. And as a general rule of thumb, dermatophyte infections are easier and less stubborn to treat than yeast, non-dermatophytic, or mixed fungal infections. It is also known that some yeasts and molds are resistant to drug use. So the type of infection will likely influence my prescription of oral or topical medication, particularly when being used in combination with laser, to ensure the most appropriate products are being used for the type of organism at play. However, I put this slide up in particular to discuss something relating to the cold laser for people that do have it more specifically. And this information I found on the website, and I've been having a bit of a discussion with a few people around their use, and something that I'm diving in a little bit deeper on with the cold laser. But as we're kind of aware of, those that know how the action of the laser works, the cold laser leads to the production of reactive oxygen species, leading to the generation of hydrogen peroxide, hypochlorous acid, and hydroxyl radicals. Now, the mechanism of this action suggests that specifically dermatophytes are susceptible to toxic effects of reactive oxygen species. Now, this possibly suggests that the efficacy of cold laser is fantastic for dermatophyte infections, but may not be as successful in non-dermatophytic or yeast cases. Again, highlighting the importance of correct diagnosis, but also an area that I'm spending a little bit of time on at the moment, looking at laser response, dermatophytic, yeast, mold and see whether this sort of statement and how the physiology of how everything works and what it's targeting, whether it is more specific to dermatophytes. So food for thought at this stage, but certainly something to consider with treatment planning. And again, highlighting the importance of why it's important to know whether we do have dermatophytics, yeasts, or non-dermatophytic infections presenting. So a fair bit of information to get through tonight, but hopefully I've sort of helped outline some of the factors that may make treatment more challenging, but more importantly, how these will influence our decision-making when it comes to treatment planning. Now, with all of this in mind, I thought we'd have a go at a bit of a case study, which will help put all of this information into practice, highlighting how this information can help manage expectations. So again, case study here is more about identifying potential challenges, things that we need to discuss with the patient about managing that patient, more so than what treatment is going to be successful at this point. Hang tight, come session 3 or webinar 3, we'll get far more into that aspect of it. So the case study here is a 34-year-old woman who presents with an abnormal right hallux for 2.5 years. She denies pain with walking or trouble putting on her shoes. She states that she is embarrassed to walk around the changing room at a gym because others will fear that she is contagious. She states that she was treated 18 months ago with oral terbinafine, but had to stop it after 4 weeks due to a problem with her liver. She gets pedicures every week to cover up her ugly nails. She is unwilling to take pills anymore and asks for your expertise in treating her with cold laser. She brings a report of T. rubrum culture from the right hallux. You examine all 20 nails, including the hands and feet, and notice that she has onychomycosis and subungual hyperkeratosis involving the right hallux. The infection involves 60% of the hallux nail with thickness of more than 2 mil, and it appears as though the lateral margins are involved. There is a scale in the interdigital web space between digits 1 and 2 on her right foot. So if this patient presented to my clinic, which very, very similar case studies present all the time, it is important that we can identify and discuss potential positive and negative factors that is going to help us better manage patient expectations. Conversely, if this patient came in wanting cold laser and we slapped her foot under the laser, took her money and hoped that we're going to get a great outcome, we're probably almost guaranteed to get a poor outcome because we haven't taken into consideration the factors that we need to address first. It is important to patients that we provide them with positive prognostic factors as well as the negatives. So often the patients arrive pretty despondent about exhausting many treatment possibilities, and therefore only discussing negative prognostic factors may make the patient pretty despondent. So in this case, we would explain to the patient that she is of an age that research indicates that she's more likely to respond well to treatment. Positively for the patient, their infection only involves 60% of the nail plate and the matrix is not involved, which does make our cold laser treatment more successful in these cases. Additionally, she has a dermatophyte infection, which is important to explain that this type of infection does respond very well to treatment, and particularly the cold laser. The patient is obviously highly motivated to treat their infection, which is also incredibly exciting for them, but also for us as clinicians, as adherence to a full treatment protocol is really key. Patients can also present quite despondent that they aren't able to take the oral medication because they do believe it's this kind of wonder pill. I would explain to patients, or this patient in particular, that due to the lateral margin involvement, oral medication and the onychomycosis for that matter, oral medication has not been proven to be highly successful in treating patients with this type of infection, as we've already discussed. And this is likely to start giving the patient a greater deal of hope, but also what it's doing is it's allowing the patient to understand that you know what you're talking about. I would explain to this patient that she has a few negative prognostic factors presenting on her nails, including the lateral margin involvement and subungual hyperkeratosis. And of course, I would explain why these factors may negatively influence the treatment, as we've already discussed earlier tonight. Therefore, we would recommend that we remove the negative prognostic factors prior to embarking upon treatment. Now, for this patient, she refuses to have the lateral margins cut back and the thickness cleared away because she believes that it will look more ugly. This is fine. Treatment can be attempted without doing this, but the patient embarks or should be embarking upon treatment knowing that if we do not remove these factors, we are less likely to be successful. Alternatively, you plan to start treatment over winter, if possible, country to country dependent, state to state dependent, so that the patient will be in shoes and socks, making ugly toenails more acceptable for the patient. It is important that a treatment plan is designed and constructed with the patient in mind, using that kind of patient-centered care model. Obviously, for this patient, a lifestyle factor that we do need to address is her footwear use. So obviously, we would like our patients in open shoes whenever possible. However, if this is not possible, we discuss why closed-in shoes are bad for the infection. We're creating a warm, dark, damp environment, but we also discuss ways in which we can mitigate environmental risks to improve treatment success. We also want to explain to patients that your long-term prognosis may be impacted by reinfection along your treatment journey. She uses communal showers, she gets regular pedicures, with potentially unsterilized equipment. She has ongoing athlete's foot, which needs to be treated. All of these lifestyle factors need to be addressed. You could have the best treatment protocol in the world, but if a patient keeps reinfecting themselves, they're always going to blame a failed treatment protocol, rather than looking at what they are doing if you've not highlighted them and addressed those aspects that need to be addressed. So, in a nutshell, these are the types of things I'm always thinking about and discussing with patients when they enter my clinic, far beyond, you have a fungal infection, this is the type of treatment we're going to do, go. Because patients really need to understand what challenges face them as patients when trying to treat their infection and what we can do to help mitigate these challenges. These will not only get better buy-in and adherence to a treatment protocol from a patient's perspective, but ultimately, hopefully better patient outcomes and less difficult conversations to have later down a treatment journey. And as I talked about way back at the start, trying to avoid those kind of dreaded conversations that you're having to have later down the track because of failed treatment protocols. So my final words in this space is, don't allow your patients to blame a treatment protocol for poor outcomes. It comes down to sort of the old saying that failing to plan is planning to fail. Plan everything, address everything, and hopefully patient outcomes will improve, making it far easier to manage your patients. So again, here are all my details on the screen. Please do not hesitate to contact me if you have any clinical questions or would like my opinion on any cases that you are struggling with. Always happy to provide my opinion if and when required. And next time we meet for webinar 3, which will hopefully be well after conference, I'm hoping to bring all of this information together, both webinar 1, webinar 2, and present to you sort of real life case studies, the factors that were involved, treatments used, and outcomes achieved, which should provide everyone with some real life learnings of the information tonight in practice, and hopefully will sort of tie everything up together. So hopefully it'll make a really logical webinar 1, 2, bring it all together in 3. And that, everyone, is the end of the webinar as such.